Okay, so what's your basis of recommending this test? You said it should be done, in most patients.
We think that since it's toxoplasmosis is a rare infection, and since our study yield that about 55% of them having seropositivity, we think that they must be diagnosed and managed in a proper way to treat them and also to manage to prevent this disease.
Have you got negative control?
Yes, Prof. 2 negative control.
Yes.
2, yeah, for our study. 2 negative controls, 2 positive controls.
You are taking the toxoplasma antibody positivity in patients with ocular signs and symptoms, right? Okay. Have you also got the prevalence of the positivity in a completely normal population?
Yes, I got, Prof. In fact, it's just here. I written it. Nisa Paton and Abdullah, 2004. 30% of, they said 30% of prevalence in Malaysia in the year 2003.
That's what I'm saying. Do you have your own control? Do you have a group of negative patients whose blood is also taken for toxoplasma antibodies?
No, Prof.
No.
Yeah, I thought you should have that for comparison. Because now you have 55% positive, seropositive, but you don't know whether in a normal population without the ocular signs, whether they would also be 55% positive for toxoplasma antibodies.
Thank you, Prof.
Okay, that's the end of the second
Thank
2
you.
minutes of Q&A for group 33. Thank you, Mr. Tinesh. Now let's proceed to the 8th presentation from the Tissue Engineering Center. A study was performed to compare the clotting profile and growth factors concentration between platelet-rich plasma, PRP, plasma, PPP, before and after freezing. We would like to invite Ms. Chai Zi Teng to begin her presentation.
Good afternoon to all the honorable judges, respected lecturers, and my fellow friends. So I'm representing Group 42 and represent the difference in clotting profile and growth factor concentration comparing PPP, platelet-rich plasma and platelet-poor plasma. So plasma clinically has been widely used, for example, as fresh frozen plasma in treating coagulation disorders. Plasma can be divided into platelet-rich plasma, which is PRP, and platelet-poor plasma, the PPP. PRP is the plasma fraction concentrated with platelets, and PPP is the plasma fraction low in platelets. PPP has been used as fibrin glue, scaffold, or cell carrier in tissue engineering. Basically, tissue engineering combines 3 key elements, namely the 3D scaffold or cell carrier, the signaling molecules or the growth factors, and the cells. These 3 key elements is very important in forming the tissue engineered construct in regenerative medicine. Plasma, other than acting as a source of growth factors, also act as a 3D scaffold or cell carrier, and this is how a scaffold looks like, and it actually follows the shape of the container. In general, we would like to determine which fraction is better for tissue engineering. Is it the PRP or the PPP, and is it the pre-frozen fraction or the post-frozen fraction? Based on the criteria that it has higher growth factor concentration, it clots faster, and it degrades slower. So we hypothesize that PRP has higher growth factor, specifically the TGF-beta1, the PDGF-BB, and then the PPP, and PPP clots faster than PRP, and lastly, freezing reduces the growth factor concentration and prolongs the clotting time of tissue engineered construct. In this study, we've chosen 30 healthy volunteers aged between 20 to 35 years old. We obtained written consent from them, and we've been approved by the research ethics. First, we obtained 40 ml of blood from each volunteer and spun under different centrifugation speed, where PRP at lower speed and PPP at higher speed. Half of the sample was analyzed immediately, and another half was frozen under -20 Celsius for 2 weeks. All the samples are subjected to measurement of platelet and fibrinogen concentration, the growth factors concentration, specifically the TGF-beta1, the PDGF-BB, clotting time for tissue engineered construct, and also the degree of construct degradation. So growth factor concentration is measured using ELISA method. The clotting time of tissue engineered construct is determined by measuring the time needed for the construct for the plasma to clot after we've added calcium chloride and cells. And for the degree of degradation of construct, we did it during the 9th week by looking at the changes or the percentage of degradation seen. So let's see, the dark blue one is the PRP, the light blue one the PPP, and on your left is the pre-frozen, and on the right is the post-frozen. So first, for the platelet count, we found that PRP has higher concentration of platelet than PPP in both before and after freezing, and the freezing process reduces the platelet count. For fibrinogen content before freezing, there is no significant difference between PRP and PPP, and after freezing, PPP actually has higher concentration of fibrinogen than PRP. Freezing prolongs the clotting time, and we found that after freezing, PPP clotted slower than PRP. In terms of degree of degradation, before freezing, PRP degrades faster. However, after freezing, PRP degraded slower. TGF-beta1 is also seen to be reduced after freezing, and it is more in PRP. And for PDGF-BB concentration, freezing increases its concentration, and it is the PRP which has more concentration of PDGF-BB. So what actually happens during platelet activation? Normally, platelet has receptors and glycoproteins on its surface, and the fibrinogen will bind to the glycoprotein 2B3A, while the thrombin will bind to the thrombin receptor. So when there is activation of platelet, in this case where the freeze-thaw cycle happens, there is increased expression of glycoprotein, then more fibrinogen will be bound to the glycoprotein, hence resulting in less free fibrinogen in the plasma. And this is why PRP, which has more platelet, contains less fibrinogen. And why PRP clots faster than PPP after freezing? When platelet gets activated, there is increased expression of thrombin receptor, leading to more binding of thrombin to the receptor, hence more conversion of fibrinogen to fibrin, and then the PRP clots faster. We also found out that PDGF-BB increased after freezing. This is because the platelet activation due to the freeze-thaw cycle process leads to more release of PDGF-BB. However, TGF-beta1 decreased after freezing due to its higher susceptibility to degradation, and this is supported by Rutkowski J.L., who reported prolonged bench set time of after 3 hours of centrifugation will result in decreased TGF-beta1 but not PDGF-BB. Next, why PPP degrades slower than PRP before freezing? Okay, PRP is spin at the lower speed and hence retain more fibrinolytic agent. When there is more fibrinolytic agent, the construct will be less stable and it degrades faster. Whereas in PPP, there is less fibrinolytic agent, therefore the construct degrades slower before freezing. Surprisingly, after freezing, the PRP is the fraction that degrades slower. This is because the freeze-thaw cycle process leads to degradation of the fibrinolytic agent, and this leads to less fibrinolytic agent remaining, thus the more stable is the construct, and the construct degrades slower. Our findings are supported by Zougolis et al. And Sophia Patterson, who reported that there is enhancement of the structural stability of PRP tissue engineered construct. As a conclusion, PRP has higher PDGF compared with PPP. Freezing increases the PDGF-BB and clotting time. Post-frozen PRP degrades the slowest, meaning it's the most stable construct, And lastly, post-frozen PRP has higher TGF-beta-1 and it clotted faster than post-frozen PPP. Therefore, we recommend post-frozen PPP as a more useful fraction in tissue engineering. Here, we would like to acknowledge everyone who helped us in the study, and with that, thank you. Any questions from the floor, please?
So from your study then, what do you suggest in tissue engineering?
So we suggest post-frozen PRP since it has higher PDGF-BB concentration and the post-frozen fraction degrades slower.
What about the TGF-beta-1 that you were saying, whether is it increase or decrease in post-frozen?
In post-frozen, if comparing PRP and PPP, it's the PRP fraction that is higher. But if comparing the PPP fraction pre and post-frozen, it's actually the pre-frozen higher. But we have to compromise and with weight, which is more beneficial, and we found out that the post-frozen PRP is the more beneficial one, although we have to compromise some of the aspects. Any more questions from the floor? If there's no, I'll end my presentation. Thank you.
Thank you, Ms. Chai. Next, we will have presentation from the Department of Medical Education to share with us about their concern on the importance of self-awareness in developing the reflective skills among third-year medical students of University Kebangsaan Malaysia. Therefore, without any delay, let's invite Ms. Hani Azmina Nur Azmi from Group 40.
Assalamualaikum and very good evening to honorable judges, all my lecturers and my fellow friends. My name is Hani Azmina, a representative from Group 40 who would like to present the research title of Importance of Self-Awareness in Developing Reflective Skills Among Third-Year Medical Students in UKMMC. Okay, we all well known that medical students have high level of IQ, but how about their EQ? Okay, now we go to the background of our study. Individuals with high level of emotional quotient are seen to be highly capable to cope with their problems and emotions, and self-awareness is an important component in EQ. It was defined as awareness of one's own feeling and ability to recognize and manage this feeling in a way that one can control it. Self-awareness and self-reflection are closely related, and both are important to produce medical students with professional behavior. Okay, study done by Victor Deloes had proposed that are 7 components of EQ, and self-awareness is one of the important components in EQ, and also comprised of honesty, self-confidence, accurate self-assessment, and emotional awareness. Okay, this is the objective of our study are to determine the association between self-awareness among medical students with factors contributed to it, such as gender, learning style, and performance in communication skill or SKI-PPD, to determine the relationship between self-awareness and reflective skill of medical students, and then lastly, to study the effect of teaching intervention to improve self-awareness and reflective skill among medical students. Okay, now we go to the material and methods. Out of 219 of third-year medical students, we have been selected 75 students using systematic random sampling. Initially, we supposed to get 94 students as our sample size, but due to lack of cooperation and time constraint, we only managed to get these numbers. Okay, among this number, we do get their demographic data such as gender and ethnic. We do give them few tasks to be completed, such as learning style inventory to identify their learning style, and reflective writing 1. Okay, we did get their OSCE PPD result and MECI results. Okay, a bit on MECI. MECI stands for the Malaysian Emotional Quotient Intelligence Inventory. it is used for measuring tool of self-awareness in our study. It generates personal profile report that can be compared to the Malaysian norm. Okay, among of this number, we further divided into intervention and control group. We supposed to get similar number, but due to lack of cooperation, only 30 students left in intervention group, while 44 students left in control group. The student needs to undergo few intervention program, which I will show it later on. And finally, both groups need to do Mackey and reflective writing again. Okay, this is the interventions program done, which is 2-hour movie session titled Of Wit. And the first SCD is regarding to identify the strengths and weaknesses of movie's character. And the second SCD is about reflective writing assessment skill. For the ethical concern, our study had been approved by UKM Research Ethics Committee, and every respondent that enrolled in the study was upon their agreement and had been given written consent. For the result of demographic data shows that the female contribute 72% of our respondents. Okay, for the learning style, there are 4 types of learning style. The first one is reflector, means self-independent learner. Theorist means they enjoy complex activities. Activists mean they enjoy new and challenging activities, whereas the pragmatist means they enjoy practical based work. Most of our respondents are reflector type learner. Okay, for the ethnicity, Malay contributes 65% of our respondents, followed by Chinese, Indian and others. This is the graph shows the association between gender and self-awareness. Okay, this is the mean score of self-awareness and EQ in male and female. Interestingly, that female got higher mean score compared to male. However, there is no significant difference between gender and self-awareness. Okay, the table shows the association between learning style and self-awareness. Theorists got highest mean score compared to the other learning style. However, again, there is no association between learning style and self-awareness found. Okay, the scatter plot shows the association between OSCE and self-awareness, and the result was directly proportional. Okay, hence we do found significant association between communication skill and OSCE and self-awareness. Okay, this is the scatter plot shows the association between reflective skill and self-awareness. Since the results are scattered all over the graph, there is no association between reflective skills and self-awareness. Okay, the graph on the left side shows the mean score or reflective writing in control and intervention group. Both groups show slight of improvement in terms of mean. However, we do found significant improvement of reflective skill in intervention group only. The graph on the left side shows the mean score of the self-awareness in control intervention groups. Both show slight improvement. However, there is no significant difference of self-awareness in both groups. As for conclusion, Patrick's study had been found that females scoring higher EQ than male. However, there was no statistically significant between gender in our study. Based on Simon Cassidy's study, there was relevance of learning style to student self-assessment skill, but again, no statistically significant between learning style and self-awareness. It might be to the student only shows the trend of our student learning style. EQ related directly to communication skill based on Grewal study, but we same goes to our result where we do find association between self-awareness and communication skill. It may due to self-awareness contributed to more preparedness and self-confidence for students to facing their OSCE examination. There is association between self-awareness and reflective skill based on Henderson's study, but in our study, no association found. It might be due to the student had been lack ability to express truthfully and sincerely in reflective writing due to lack of vocabulary in English. Other than that, reflective writing not only part of reflective skill because it also can be accessed to the verbal communication. Self-awareness is a temporary state that can be changed and may fluctuate with intervention program. And improvement again was not statistically significant. It might due to long interval with the student need to undergo intervention since January and completed making on March, cause 2 months interval lead to self-awareness to fluctuate or due to lack of effectiveness in the intervention programs. Only the intervention group shown significant improvement in reflective skill due to intervention program may facilitate them to become better reflective skills. As conclusion, self-awareness is important in developing reflective skills. Students with high self-awareness perform better in question skill assessment. And lastly, the study interventions promote students' reflective skill but not their self-awareness. Okay, this is acknowledgement. Okay, thank you. Any Q&A?
I'm just curious about how do you perform the OSCE communication skill?
Okay. Regarding that question, actually we get the results from the examination, third year examination that one part of had communication skill means OSCE PPD. That's why we take their results and put in as our study.
So these results were taken after the intervention or before the intervention?
No. We take the result during semester 1, year 3. The study had been done during they undergo semester 2.
So meaning it is in the middle of the study?
Yeah.
So after the intervention or before the intervention? Meaning the SGD that you had? STD is for the intervention group only. Okay. Okay, the other part you showed us something about the movie that they had to watch, and what was the outcome of that?
Okay. Regarding that movie, we need to expose the intervention group for the 2-hour movie session because there is first SGD for them to identify the strength and weaknesses of character inside that movie. That's why we put that movie for them.
Reflective writing, right, from the movie? So you're assessing the reflective writing from the movie. The awareness is by the Mackey analysis. Am I right?
Yeah, Prof, I want to correct. We actually have 2 types of STD. The first one is about the movie character, and the second one is about reflective skill assessment. So we got 2 STD. And then yes, about the Mackey, we use for assess self-awareness. Okay, that's all. Okay, thank you.
Thank you, Ms. Hani Asmina. Finally, let's invite our last presenter of Group 28 from Department of Family Medicine to present an interesting study on determining the prevalence and associated factors of erectile dysfunction among diabetic patients. So gentlemen, you may want to pay more attention to this. Well, we will let Ms. Mashita Makrazi to present her group's result. Please welcome Ms. Mashita.
Thank you to the chairperson. Assalamualaikum and a very good evening to all the fellow lecturers and doctors and all the I'm Mashita from Group 28 would like to present our research study entitled The Prevalence and Associated Factors of Erectile Dysfunction Among Diabetic Patients at a Teaching Hospital. Erectile dysfunction, or ED, is defined as persistent inability to achieve or maintain penile erection sufficient for sexual performance. It is one of common complications of diabetics that affects 34 to 45% of men with diabetes. It is significantly and independently associated with diabetes. ED is commonly being undiagnosed. And based on these factors, we have conducted this study so that in the future, further intervention can be done to improve men's sexual health, especially among diabetes. Our main objective is to determine the prevalence of erectile dysfunction and its associated factors among diabetic patients at a teaching hospital. Specifically, we want to determine the prevalence of proven and perceived ED among diabetic. Also, we want to determine the association between ED and demographic parameters such as age, race, marital status, educational status, and income. We also would like to know the association between ED and diabetic-related complications such as peripheral neuropathy, diabetic retinopathy, and nephropathy, and also the association between severity of ED and comorbidities as well as clinical parameters. We use cross-sectional study that conducted at endocrine and outpatient clinics of UKMMC from February 2010, involving above 18 years old males who have been diagnosed with type 2 diabetes mellitus. Randomized sampling was used as our sampling method, and most important thing that our study have been approved by the UKM Research Ethic. For study materials, we use data collection form, which consists of patient demographic data, medical information, and patient perception of ED. For patient perception, we have asked the patient whether they think they have ED or not. We also use International Index of Erectile Function 5 or IIE5 questionnaire as a diagnostic tool of ED. It is internationally validated and has specificity of 85% and sensitivity of 75%. This flowchart shows how we collect the data. First, we screen the patient who attend the clinic and choose those who fulfill the inclusion criteria. After that, we collect the data by using data collection form and IIE5 questionnaire. And all the given information were ensured to be confidential, and then the data were analyzed by using SPSS version 12. Out of 335 selected patients, 281 were our respondent and 54 non-respondent because of incomplete data and non-consent. Let us have a quick glance at our patient demographic data. Most of our respondents belongs to the age group of 41 to 80 years old. Majority of them are Malays, married, and study up to the secondary school, and has income less than 1,500 ringgit. And majority of our respondents also have been diagnosed with diabetes for more than 10 years. We have asked our respondent about their perception of having ED, and we found out that 56% of them are perceived that they have ED, and 44% were denied of having ED. And based on IIEF score, we found that 87% of our respondents is proven to have ED, which is about 55% higher than perceived ED, and the balance 13% was non-ED. And we further analyzed the data, and interestingly, we found that out of 158 respondents who perceive that they have ED, 155 of them are proven to have ED. This means that 98% of perceived patients proven to have ED, and this relationship is significant with the p-value of 0.000. And this chart shows that the mean age of proven ED is higher compared to the non-ED. And we found that there is significant association between proven ED and age. We also found that there is significant association between proven ED and duration of diabetes with a p-value of 0.009. And the chart showed that the percentage of those with diabetes for more than 10 years have higher percentage of proven ED compared to those who have diabetes less than 5 years. We also found that proven ED has significant association with nephropathy, with the p-value of 0.017. Okay. However, we found that there is no association between severity of ED and comorbidities such as hypertension, dyslipidemia, and obesity, and also no association between severity of ED and clinical parameters such as glycemic control and duration of diabetes. From our study, most of our respondents, which is 86% are proven to have ED. Study from Hong Kong reported 84.3% diabetics have ED, and other study from Jordan, Italy reported a lower percentage. Our study found that 56% of our respondents perceived to have ED, while 15.9% reported by the Subang Men's Health Research. 98% of perceived patients proven to have ED. And now, audience, the take-home message that I would like to emphasize here is that if you encountered any patient who claimed that they have ED, the chances of probability that they have it is about 98%. In this study also, we found that prevalence of ED is higher among older age group. And the previous study also reported the same. And other study reported that ED is more common in men aged above 51 years than those aged below 41 years. our study also found that prevalence of ED raised with the increasing duration of diabetes. Other study found that greater risk of ED is with increased duration of diabetes, particularly more than 20 years. We also found that majority of patients with nephropathy had ED, and other studies found that significant association between nephropathy and ED. We found no association between proven ED and other demographic parameters such as race, marital status, educational status, and income. No association between proven ED and other diabetic-related complications such as peripheral neuropathy and diabetic retinopathy, and no association found between severity of ED and presence of comorbidities and relevant clinical parameters. This is may be due to diversities in study population and methodology. In conclusion, prevalence of proven ED among diabetic patients is high, and we found that patient perception is reliable for ED status and should be considered upon determining their ED status, especially among diabetics. Proven ED is higher among those with increasing age, longer duration of diabetes, and presence of diabetic nephropathy. And we found that there is no association between ED severity with the diabetic-related complication and comorbidities. Our limitation is that our result does not represent the general population, and due to limited sample size, it may cause false negative result. And also, misinterpretation of IAA5 may occur, and we also do not take into consideration if patient on any medication. So in the future, we would recommend multi-center area study with larger sample size using IIEF various languages, and also we should screen routinely on patients who have longer duration diabetes and elderly. That's all. So, judges, if you have any question.
Okay, I just would like to ask you, is the IIEF the only tool to measure that the patient definitely have ED? Or there is any other, from the study that you quote just now, do they use the same tool, or they have other tools as well?
Actually, in our study, we only use IIF5 questionnaire, but the other study also have also used other methods such as NIH criteria, which reported lower percentage of proven ED.
So meaning from this IIEF, you are asking some basic question, am I right?
There are 5 components of question that we ask.
So from this question, you can confirm whether they have.
It's actually we must do for definite diagnosis of ED. Of course, we must correlate with the clinical assessment also. It's just for screening.
This is not an naughty question, but rather than asking for perceived ED and IIEF application, what about asking the wife?
Oh.
Thank you, Miss.
May I answer that question? That is maybe due to sexual satisfaction more than erectile dysfunction. Sexual satisfaction of the wife, not the satisfaction of the male.
Thank you, Ms. Mashita. Ladies and gentlemen, we have reached the end of the oral presentation and have witnessed lots of interesting and informative research. We hope every member of the floor has benefited from this event. We'd like also to send our greatest gratitude to our judges, Professor Zaleha, Professor Yasmin, and Professor Karis for their tireless effort in judging every presentation. While the judges are counting the mark, we would like to welcome our special guest all the way from Universitas Airlangga, Unai, Indonesia, to present their review article on short-term effect of laughter on blood pressure of elderly hypertensive and normotensive patients in Watugal rural area, Lawang, Indonesia. Besides that, there is poster presentation from Unai as well, titled Utilization of Olenonic acid, gallic acid, and antioxidant compounds in pomegranate flowers as new therapy of type 2 diabetes mellitus. Then we shall begin the award presentation and closing ceremony at 4:30 sharp. Welcome.